Yeah, so I think that's a very pertinent question as to what got us interested in instituting some form of artificial intelligence in our Echo Lab. So I started working at City of Hope in 2017, and when I first arrived, I felt that the entire purpose of our existence in a cancer center is to make sure that we are providing accurate, reliable, reproducible evaluations of cardiac function so that oncologists can make well-informed decisions on whether chemotherapy can be delivered, whether a patient can withstand the stress and demand of stem cell transplantation, whether they can withstand immunotherapies and CAR T-cell therapies. And that was the entire objective. I wanted to make sure that our reports were accurate and we were providing reliable information. And the problem with, I think, echocardiography and cardiac ultrasound at large, is that it's more of an art. There's a great deal of variability in echo, and there are many reasons for that. So there's variability in the sonographers who perform these studies. There is variability in their ability to acquire good images, and obviously there's differences in machines and different vendors, how we process the pictures. And then there is variability amongst reading cardiologists and how we see the heart, where we take measurements, and then how we report those measurements. So I wanted to standardize as much of this process as I could. So obviously we developed a standardized protocol on how we're going to perform the echocardiogram. Then we developed standards for how we're going to report function and what techniques we were going to use. And ultimately, I think there was still a fair bit of variability in reporting of a measurement as simple as ejection fraction. So, an oncologist who's ordering an echo, their primary interest is, what is the EF? And I think I felt like it was incumbent upon us to report an accurate EF and not have differences between readers. Unfortunately, if you read published studies on variation between readers, it is nationally acceptable, or it's accepted, that there is going to be a variation of about 10% between readers in reporting of systolic function. And I see this as a huge hurdle in the practice of cardio-oncology, because we define cardiotoxicity as a drop in ejection fraction by 10%, 10% below the lower limit of normal. And so the amount of variability that's acceptable on one hand is exactly equivalent to what we would define as cardiotoxic, and it can impact patient care and outcomes ultimately if somebody's chemotherapy is withheld because we're reporting such varied values in ejection fraction. So that was my initial thought, is like, how do I make this better? How do we narrow the gap and the variation in these reports? And we needed a neutral, objective method to accurately and reliably measure ejection fraction. And so I sought out different solutions, and artificial intelligence was sort of a natural conclusion, because this is something that is going to do things in a very systematic and reproducible manner. And Ultromix was one of the front runners at the time in the AI space in echo. And so that's when I initially reached out, and we decided that we were going to pursue a trial to see, okay, well, we want it to be better than us. So is it going to be better than us or not? Are we going to be able to use it? And so we wanted to try it out before we made any commitments, and so that's how we started working together. I think I would say that we ended up working initially with ejection fraction and global longitudinal strain, but then the company since then pivoted into disease identification, and that actually has been kind of eye-opening, because that wasn't something that we were initially even thinking about. And I think it's fairly remarkable in terms of how much things have advanced. And we were talking about just simply let's just do the measurement and see how good that is, but we weren't thinking about being able to identify heart failure or identify amyloidosis. Those kinds of things we were imagining. I mean, we weren't even really imagining it, frankly. So when that started happening, I think we found that we're achieving more than what our initial goals were, as I think the standard of care that we're providing has notched up with the inclusion of these identified entities in our reports. So I think we talked about needing institutional buy-in. I think when it comes to most folks working in academic centers, a very significant key to success is patience. So you need to have patience with your institution. You have to have patience with your IT folks. You have to have patience with your sonographer staff, because even sonographers will initially be a little wary of new technology. And then patience with your colleagues, both within cardiology as well as within the institution at large, the ordering folks, because they're going to see these AI solutions being instituted and they're getting back reports. And it takes the whole village to move the needle forward and learn to work with this. Because I think initially there can be pushback as to, like, why are you reporting this? What am I going to do with this? That sort of thing. So I think that's probably the most important part, is being patient, but also being, open to, progress doesn't happen without change, and that requires being open to it and being patient, but persistent. Yeah, I think that's a good question. This is something that we didn't do, but I would advise is to have a plan for, what you will do after the fact. So you're gonna implement this solution, and then you're gonna start getting positive reports. So what are you gonna do with these positive reports? I think that's something that we had to deal with in real time. So suddenly we would get a positive report, and my faculty would say, hey, I'm reporting this positive. Should we do something with this? Like, we'll report it back to the ordering doctor, but what are they supposed to do with it? And I think that's where we had to sort of develop some organized, systematic manner in which we were going to work with the positives. And it's up to different folks to decide how they want to address that. What we've done is we've got a standardized method by which we report it. We have a statement in our echo report mentioning the positive. We mention the probability score, and if there are very significant signs of heart failure, we will also recommend referral to our heart failure clinic, or to amyloid, for example. So if the study is coming back positive for amyloid, then we will recommend referral to the amyloid clinic. But it's I think that's something that we had to work to develop, that we were going to receive these people and how we were going to assess them. So that's probably the biggest sort of advice in terms of how you would want to be prepared once you institute something like this.